Very good. Getting ready to start. Okay, we're going to continue on with endocrine. Like I said, if you were hearing before what the plan is, so I'm trying to get the electrocardiogram and I'll get in. I mean, if you haven't, I mean, if you have questions specific to the exam, I'll, we can do them at the start of lab if you wish. I'm fine with that. You know, I mean, but I'm not going to go over and re-narrate that thing with the power with the test exam in front of me again. That's getting old. Sorry. Nevertheless, endocrine system. Let me see where we left off. There are too many words. Visual system. Where comes paracrine. So we did all this stuff. We did all that stuff. You listening?
I don't think it's on.
Okay. Oh, thank you. Oh, here we are. That's where we left off. So we'll take it from there. And there's a lot of this. Really would rather spend our time going over the specifics. Today's the day we're going to get the pituitary and the relationship of all the hormones really covered. That's part of what today's presentation is. So there are different things that most of the time the stimulus and the controls over this are typically hormonal in nature. One hormone will positive or negatively feedback, and sometimes it'll be things in the blood, like calcium levels, for instance, would be a humoral stimulant. The only one that's sort of the oddball is the neural override, and really that's fight or flight. You know, when you enter fight or flight, your autonomic nervous system kind of takes over and creates an outpouring of endocrine, particularly epinephrine and norepinephrine, by way of the adrenal medulla, which really, it's not so much an endocrine system; it's sort of really more part of the autonomic nervous system. But here we'll go with it. So ions and nutrients. This is the way calcium and parathyroid hormone directly related to this class of negative feedback. Glucose levels will play a role in this, sometimes associated with insulin release or glucagon release. We'll get to those. So those are specific chemicals. So when you use the term humoral, the implication is dissolved in your bloodstream. Chemical agents, ionic agents, things that are dissolved in the bloodstream. And they're just showing you, what it's going to affect here, the parathyroid. We'll get to that. This is sympathetic nerves and catecholamines, particularly the adrenal medulla. Again, it's probably the example they always use, and I don't think it's a great example other than being an override, because to me it's really just an extension of the autonomic nervous system. That's fine, even though depending on the author, they will give it some, because you're releasing epinephrine and norepinephrine directly into the bloodstream. The implication is that this is endocrine-like at the very least, would be the way to describe it. And then, and really, hormones stimulating other hormones. And this is the classic, when they talk about the ARC, the hypothalamic pituitary target organ feedback loop. This is the way most of the things work. If it's not dissolved chemicals like calcium or glucose or other chemicals, we're looking at hormones. So in reproductive, we'll be looking at estrogen and testosterone, progesterone levels, things like that would be a classic example. When you're looking at humoral, maybe you're looking at salt levels, or you're looking at osmotic levels. The osmolarity or osmolality of the solution will be an example more of humoral. I'm just giving you some ideas of how you would distinguish. I'm less inclined to ask a specific question about that. It's more for your understanding than for me to challenge you on a series of words. I'm picking it enough. That's the world's biggest grape. Ah, my wife would be having a party. My wife is addicted to cherries. It's awful.
It's awful about cherry.
No, she's like, there's an obsession. And every so often they'll have them at Shop and Save. They'll have one of these sales where they're like, from $5.99 they're like half. They're like $2.99 a pound. And I'm in there buying bags of cherries. Not only is she forcing me to go to the gym, she's making me eat salads. It's not fair.
It's not fair.
It's not right. I've never been treated so disrespectfully. Okay. So really, this is what we're looking at. They express it graphically better than I could draw it. So basically, hypothalamic hormones, because remember the hypothalamus, where the blood-brain barrier is weakest, stimulate release of most of the anterior pituitary hormones. This is where we begin to focus on them. Maybe I should just put it up there just for. It's worth me doing it again. I'm sure they'll show it to you better than I am. My camera. So what effectively we have, again, the hypothalamus. Why is that significant? Because that's the area where the blood-brain barrier is more permeable. So it's weakest there, and that's where there are sensors. So it's in more intimate contact and more sensors for chemical levels in the bloodstream. That's the read area. That sends that signal to effectively the extension of the hypothalamus. You might remember from anatomy that little tongue-like is called the infundibulum. It's really part of brain that protrudes down, and that infundibulum effectively becomes the posterior pituitary or neural part of the pituitary. I won't throw it out. And then that will send signals to the anterior or glandular pituitary. You'll see the names in a bit. And effectively, we can generate feedback even from the response of target organs, even from the pituitary, even from any of these areas potentially can feed back on that system and impact it. So it's got a lot of controls. And then we talk about the arc. In MCAT, we talked about one of these, for instance, things that come out of the posterior pituitary, and we'll probably get to that today, famously oxytocin, vasopressin. VASO, pardon my handwriting, you'll see it again. Known as antidiuretic hormone or oxytocin, which makes genetically called pitocin, to induce labor. And then a variety of what are called RHs, release hormones, and IHs, inhibiting hormones. And when I say, so they basically are upregulators or downregulators to basically give it a Hillwiggian sense. Downstream and upstream and up, that type of. I feel like I'm portraying myself as some type of scientist. So voila. So here's the idea. They're showing the three types that are there potentially. If you want to look at these things, three types of endocrine gland stimuli. So here's the hypothalamus. Here this is that little stalk we call the infundibulum. This is the posterior, and they're intimately associated and very tight. Here you have the posterior pituitary. You'll see shortly it's called the neurohypophysis. And then the anterior pituitary, there's a very elaborate capillary bed that makes the communications very, very, very rapid between them. It's almost instantaneous. And so you have and it's called a portal, Portal system. We'll see that in the liver. Whenever you have normally a capillary bed goes into a vein, and then that vein will go back to the heart. When you have capillary beds in sequence, they are called portal, Portal. The famous one is here, and there's another equally as famous one that you will see when we start talking about the liver, the hepatic portal system. And so here you can see, for instance, stimulating the thyroid gland, the adrenal gland, and those are the three of the major areas that anterior pituitary hormones go to. So, and nervous system, it's certainly an override if you want to think of it that way. So it can override normal endocrine under stress, that's fight or flight. So the hypothalamus and the sympathetic nervous system override insulin to allow blood glucose levels to increase. And understand, we're going to see that a lot. When insulin, if you want to think of it from sympathetic, parasympathetic, insulin is much more associated with rest and digest. We're secreting insulin and utilizing sugar as an energy source to do most of the things we do when we're at rest. Digestion, genitourinary function, that kind of stuff. When we're not at rest, when we're in action, we want to keep our glucose levels high. We're going to release more glucose from the liver. by way of glycogenolysis, et cetera, et cetera. Used to store glycogen and convert it to glucose for muscle activity. It's just kind of the way it works. There. I was pretty happy with my resting heart rate. Oh my goodness. Oh yeah, I got right. I had my doing my disco tunes. It's upbeat. It's great to exercise too. Getting in touch with my inner Bee Gees. It's like Saturday Night Fever all over again.
Very good.
Oh yeah, I have Katie on. That's all right. I'm weird, but you already knew that. Specificity. Every endocrine hormone has a range, sometimes very broad or very limited. Human growth hormone, every cell. Insulin, basically every cell. ACTH, adrenocorticotropic hormone, the adrenal cortex, period. Okay, so receptors are found either only on certain cells, and when we use thyroid hormone, nearly all cells. So that's the range of those particular chemical agents. You have to understand them. And the factors that are involved, typically blood level, certainly number of receptors, how well they bind. That's very basic. I mean, I'm not going to get into the whatever the pharmacodynamics and all that type of stuff that you would do. Not interested in that. I mean, that means just, the more you have on there, as long as there's available receptors, it'll trigger them. We'll assume for the moment they bind. And effectively, when they talk about this up and down regulation, so if the hormone levels are low, more receptors form. If they're high, receptors will not form effectively. So it'll almost desensitize the target. It'll lose the receptors. So that's interesting in and of itself, to be that sometimes the hormonal levels play a role. You're going to see that a lot as we look in this latter half of physiology. Really what happens, the system adapts to not just neurotransmitters or hormones, but almost anything has potential to alter the receptors to accommodate to different, things change all the time. Just like now that we're, all of a sudden we're out of this Arctic North blast. Okay. It's just so annoying because my son, who's moved to Fort Myers, is showing me pictures. Oh, I was out by the docks fishing. We covered this before. If it's fat soluble, steroidal based hormones, or the very symmetric thyroid hormone, it requires some type of plasma protein molecule that are there. And certainly levels of that, rate of release, speed, which is an activated remove, standard stuff. So whether it's enzymes that degrade it, or it's just passing through in the kidneys or the liver, and again, to me, kidneys don't so much degrade things as they rely on degrading enzymes in the liver to effectively break them down and make them more water soluble. What the kidney does once they're more water soluble is allows them to pass. And again, and sometimes we utilize that very famously. Every so often, if you're going into a medical field or somebody who's got some kind of an imbalance, they'll have them collect 24-hour urines. Because sometimes there's so little in just a random urine sample that you need to collect a day's worth of urine and bring that into the lab and let them attempt to extract and assay the level of the chemicals. And that's not that unusual, by the way, particularly when you're doing an endocrine workup. And half-life, you're all familiar with that. The biological term vis-a-vis half-life is the time required for the level of any agent. It could be a hormone, it could be a pharmaceutical agent, it could be a prescription drug. The time required for the level of that to decrease by half. It doesn't mean it's inactive. That's a real, it's a stickler, particularly if any of you going into clinical fields, you're going into medicine, pharmacy, physician assistant, any of that. Understand we have a lot of medicines that have what we call active metabolites. These are breakdown products that have activity. Notoriously, one of the early sedative hypnotic agents is Valium. We still use it today. I use it all the time. I mean, I prescribed it a lot. The good news about Valium is it's very effective at, relieving apprehension. And if you take enough of it, maybe getting somebody to go to sleep. The bad news about Valium is it has active metabolites. So somebody who's not used to it could wake up in the morning, get ready to drive to work, and really probably shouldn't get behind the wheel. Some people it affects more than others. I remember getting called about by a pharmacist. And as a doctor, sometimes you get angry. Oh, why is the pharmacist telling me what to do? But he told me something I didn't know. He said, "Look, I'm a little. You prescribed this. I want you to understand that we need to include this on the prescription information, and we just want to make you aware of it." He wasn't challenging my ability to prescribe it. He made some suggestions about other agents I might want to use. And if you're smart, you'll listen, even though it's somebody who's in a different field than you are. Okay. So different response times, immediate, and again, the faster it responds, the shorter it lasts, the longer it takes to respond, the longer it lasts. And a lot of them are inactive until they get to the target cell. So as you can see, seconds to hours, different things, there's a wide variation. All of these are significant that are there. And so you can read through this, what it is. There are some examples like this. For instance, when we get to thyroid hormones, thyroid, if you did not know, basically is sort of like your body's engine. It's how fast we do metabolism. So when you're hyperthyroid, you're metabolizing things very rapidly. When you're hypothyroid, too slowly. And so euthyroid or normal thyroid is obviously the goal of the exercise. But it's interesting, vis-a-vis reproduction, it plays a very unique role in the sense that the thyroid hormone has to be there for them to even have any effect whatsoever at the appropriate levels. It's a lot of things work together. That's permissive synergism. Okay, and when we do diabetes, I'll go into it in a little bit more length. A synergistic effect means they work together to accomplish the goal, even though they're opposite. So glucagon and epinephrine are synergistic in the sense that they'll cause the liver to undergo glycogenolysis. And in fight or flight, we release glucagon and we release epinephrine. They're both going to end up with the same thing, making blood sugar available. You're going to see that, interestingly, even though the effects are opposite when we talk about diabetes, glucagon and insulin are very often effectively secreted very, very close to one another. And it's because, as I'm fond of saying, living systems do not make sharp turns. When your sugar goes up, it doesn't come up and go right back down like that. That's irregular. And so we often see the sugar being elevated and then rapidly declining, but there's a slowness when it sort of changes directions. And that's because living systems don't make sharp turns. When they make sharp turns, it suggests that something's off, and moreover, it points to the fact that that system might fail. And that's one of the little giveaways when we start looking at things like people who are pre-diabetics. I don't know about a lot of things. I'm pretty good on diabetes, even though I'm not a diabetic. I didn't play one on TV. No, not a disease you would wish on anybody. And even though these are antagonists, it's one of those wonderful things that we see in this system called dynamic antagonism. Again, one is sort of softening the blow of the other. Very, very useful. If you did not know, in pharmaceutical science, oftentimes we'll prescribe a medicine and prescribe another medicine to make sure that the response is not so severe. It almost moderates or mitigates some of the severity of the response. It's almost like what the medicines do are a side effect, and you're almost prescribing something to avoid the side effect. There's a whole lot to this. And for many of you who go into clinical fields, you'll learn about that. And you're all going to know people. And you yourself, hopefully not too much, will have medicines. Do not be afraid to ask. There are a lot of doctors out there. The answer, because I wanted to prescribe it to you, I think you need it, is insufficient. When they give me a medicine, I want to know, why are you giving me the medicine? Why this medicine? Why not another medicine? If they don't want to tell you, here's my advice. Find another. There's a ton of them out there. They're all looking for patients. Gone are the days when the doctor was some kind of pseudo deity It's a consumer-oriented society. They want your money. Trust me. But I mean, when my dad got an order from his doctor, it's like the Almighty spoke to him from the mountain. You will do this. It was a command. I mean, I remember going to see my dad's doctor and said, "Why are we doing this?" He's like looking at me like, I mean, I knew he was a brilliant man. I said, give me a break. I'm a student, medical student. Okay, I'll explain this to you. Thank you. So here's the hypothalamus connected to the pituitary gland. The gland, fancy name is called the hypophysis. Okay. And so the infundibulum is a little stalk of brain. 8 major hormones. That's the pituitary. These are the major ones, not the minor ones, the major ones so far. We'll get to the others. It has 2 major lobes. Posterior, by definition, we call them neurohormones because it is nervous tissue. It is really nothing more. They're really nothing more than neurotransmitters that are being secreted directly into the bloodstream by the neural or nervous system or brain system hypophysis. And many of them directly impact the adeno or glandular, adeno means glandular, hypophysis. And it's different. It's different if you feel it. It's different if you dissect it. It's different if you look under the microscope at it. And this is that hypothalamic hypophyseal tract. Bless you. This is the connection to the hypothalamus. And again, these nuclei in the hypothalamus, whose names you don't have to know right away at this point in time, are areas where those sensors are available to get a read, so to speak, on bloodstream levels by way of the infundibulum. Here are the 2 major neurotransmitter type hormones that go into the bloodstream. Oxytocin, which you know is Pitocin, when it's made genetically to induce labor, and ADH, or antidiuretic hormone, also known as vasopressin, which, if you did not know, is also manufactured genetically. Okay, and the name that you will see it, for those of you going into a clinical field, will see this, because it uses DD, that's sort of that AVP. DDAVP is genetically made a vasopressin or antidiuretic hormone. So we have treatment for people who are lacking either one of those. Obviously, the oxytocin slash pitocin, typically to induce labor, it's not its only usage. If you did not know, and we're not sure of the mechanism, people with certain bleeding disorders, particularly something called von Willebrand's disease. Von Willebrand's is a platelet-oriented disease. My first wife, they discovered when she had a transfusion, more on that down the road, back in 81, she was having an ovarian procedure so we could try to have children biologically. And she had a big time bleed. And they discovered after she had to have a couple of units of blood, everything was fine. So a little sketchy for about 3 to 5 days in the hospital. They did a workup. The blood bank did a workup by way of an oncologist, hematologist, and found out she had a variant of von Willebrand's disease. From that point on, if she had to have a dental extraction or any time where you have a chance to bleed significantly, we're not talking about cutting yourself at home or scraping a knee when you're out in the garden or something like that. She had to get an injection of this because one of the effects was it would bolster the ability to clot, either make platelets more available. I'm not sure. So at the time, it was in its early days. I mean, it was a shot that we would order from the pharmacy on insurance that, thankfully the insurance covered the vast majority. It was like a $600 or $1,000 shot back then. If you're unfamiliar with biologicals, they ain't cheap. Then we get to the immune system. I was on Cosentyx and Humira, not at the same time, but separately. That's a $3,000 to $6,000 shot. Take it twice a week, right? Every other week. There's a reason why on TV, how many pharmaceutical ads do you see for arthritis and stuff like that? And all those disclaimers. Don't want to be viewed as, what would be the right term? A pessimist, but it's about the money. That's the default. If you're not sure, it's about the money. Rule number one. Rule number two, if you're not 100% sure, go back to rule number one. So here they go, oxytocin, they just show you a pathway. These get absorbed, but they don't impact. It's not that they're going past it. They just don't have receptors on that. Oxytocin, fairly specific, vis-a-vis the birth canal. Antidiuretic hormone has a number of areas, but particularly the kidney. But again, it has other features as well that may, they're not going to really include in the context of this text. The anterior lobe, now I get to the good part. Glandular tissue derived from an outpocketing of the oral mucosa. In the old days, if you had to access the pituitary, now there are better surgical techniques, they would go through your mouth. You'd feel your hard palate, where you had the maxillary bone and the palatine bone we learned about in anatomy, and just past that is the soft palate, and then you'd make a cut and go up there. You're pretty much right at the pituitary. That was the way they used to do that. And so again, when you see portal, it means it's two capillary beds in sequence with a vein in between. So capillary bed to capillary bed and portal veins in between. So in addition to these things, oxytocin and vasopressin, there's a variety of what are called releasing hormones and inhibiting hormones. Releasing hormones induce the anterior pituitary to release certain hormones. Inhibiting hormones, the opposite, tells it do not release them. Either increase the release or slow down the release. So it's an elegant set of controls. And if you can read this, you're better than I am. But the big six that I like to call them, is you must know, and you have to know the acronym. You're doing RH. Comment. That's it. Growth hormone, HGH, human growth, ACTH, adrenocorticotropic hormone, TSH, thyroid stimulating. So this, all cells, here limited, the adrenal cortex, the outer portion of the adrenal. Here, thyroid. The other three are all reproductive. FSH, follicle stimulating hormone, stimulates production of eggs and sperm. Not entirely the only thing, but the major thing. LH, luteinizing hormone. Stimulates estrogen, STR, progesterone, testosterone. And then prolactin, which plays a role in lactation. We don't understand it as much as some of the others. It certainly works in concert with these, but we see it released more often. Sometimes abbreviate PRL. We see it more commonly associated with pregnancy and lactation, certainly, than anywhere else. Getting there. So, voila. So oxytocin and antidiuretic hormone, that's why they're easy to make genetically. They're relatively simple. They only have 9 amino acids, so it's not hard to construct something like that at all. They're simple polypeptides. Very, very simple. Uterine contractions, that's one of those oddballs. Positive feedback triggers milk ejection, so part of the lactation process. And you can, it is a second messenger again. These are G protein and second messenger system. ADH, basically, it works on osmoreceptors and monitoring solute concentration. If the solute is too high, it secretes antidiuretic hormone. Basically, what that does, you pull water back in. So this becomes active when we look at the kidney. You might remember from anatomy, and we'll certainly review it. You have those collecting ducts, the distal convoluted tubule multiple distal convoluted tubules go into the collecting ducts. What antidiuretic hormone does is it inserts little openings, little passageways that bring water, basically attract water back in out of the collecting ducts, bring them back into the system, so to speak, and out of the distal convoluted tubule. So you're bringing more water, and so there's less water to urinate, hence the name against diuresing, making urine hormone. And other things, pain, low blood pressure. And so exactly why it has that impact on clotting, I do not know exactly. I probably should look that up. What's interesting about that, and this is something that, I mean, for those of you who imbibe, those of you all know this about alcohol. This is why alcohol it's got a lot of problems. Originally, alcohol was used as a general anesthetic. The major problem is the lethal dose of the therapeutic dose to create anesthesia and the lethal dose of alcohol are very, very close. That makes it a high risk to do that. It's got a very pure, what's called therapeutic index, number one. Number two, it throws off, okay, it causes vasoconstriction, and also basically what antidiuretic hormone is, it opposes it, and it plays a significant role in clotting. That's the other reason why alcohol is a particularly poor, and they used to use that a lot. I mean, it was like in the old Westerns, they tie somebody down, give them a bottle of booze, and start cutting. Go ahead.
If alcohol inhibits ADH, then why do you have to go to the bathroom?
Because it inhibits ADH.
Oh, I thought it's...
Yes, the other
I
way.
was thinking
It makes you diurese.
Okay.
And then, and it's the old story. It just seems like once you start, there's a degree of frequency. It's not that I don't drink a lot. Other than that week in Cancun when everybody was drinking drink too. We were drinking to excess then. I like flavored margaritas. I like those kinds of drinks. I was not drinking the straight shots of tequila. I did not delve into my son's extensive bourbon collection. Designer bourbons, $160 bottles of bourbon. Just saying. And there was a fair amount of cerveza involved. There was Modelo, there was Dos Equis. That seemed to be, I don't know, just saying, not for me. So, deficiency disorder, diabetes insipidus. What does diabetes mean? No, the word diabetes, not the disease. The great thirst. There are two types of diabetes. Diabetes insipidus, which is the ADH deficiency, and diabetes mellitus, okay, with a small m, Ellitus. So this is known as salt diabetes. The other is known as sugar diabetes, because in the urine was unusually salty, okay, for whatever reason, compared to spilling. There was more likely spilling salt in the urine than there was spilling sugar in the urine, which is the characteristic of diabetes mellitus. And because of this antidiuretic hormone deficiency, you urinated a great deal. I mean, it's basically the treatment. Well, one, we certainly can now make this genetically, so it's not a big problem. But other than that, trying to keep somebody well hydrated was very, very important. So, and now sometimes we get this inappropriate ADH secretion, okay? And what happens now, you're retaining so much fluid, headache, disorientation. That's a lot more difficult. We have to, since we have something that can take the place of it, and genetically is equivalent, but having something to oppose it, we don't necessarily have. It's like with thyroid. Thyroid supplement's been around forever. We're talking more than a century. Thyroid supplement, but drugs that combat for hypothyroid or surgically remove thyroid, good to go. But hyperthyroid, harder to treat, more side effects. So I mean, and that I don't know if that's necessarily recurrent. Here you have what I call the big six. You got to know all these. When they say tropic, I mean, I don't buy that. To me, when they say tropic, regulate secretion of other hormones. Tropic to me is part of trophy, which means growth. Autotroph, self growth, heterotroph, like we are. We eat almost anything to grow. Okay. Trophy means growth. I mean, I don't necessarily buy that. Okay. So, I mean, if they wanted to make that definition, that's fine. I'm not going to ask you about it. But effectively, I mean, growth hormone certainly regulates the secretion of other hormones. So I don't know why they have that context. I can buy prolactin because we really don't understand it. But thyroid induces the thyroid gland, if it's possible, to secrete more thyroid hormone. Here, there are three different levels of adrenocorticotropic, three different levels of adrenocortical hormones. Follicle stimulating, I mean, there's some hormones, but those hormones, the actual end product of that follicle stimulating is not that. The end product of follicle stimulating, sorry, the actual impact of, don't have children, you never know. The impact of follicle stimulating hormone is that's going to cause eggs and sperms to develop, which is not really, to me, that's more growth than it is. And surely there are other hormones involved. And luteinizing, as I mentioned before, estrogen, progesterone, and testosterone. So take them in the batting order. We'll get a little nugget on each of these. Might get through them all. Somatotropin, produced by somatotropic health. Somato means body, tropic means growth. Okay, direct actions on metabolism, indirect on growth. I say this to you a lot. There's this kind of relationship between insulin and growth hormone. We grow a lot with insulin. When we eat something, our body is designed to basically use carbohydrates as an energy source and direct metabolism, increasing cellular repair, increasing various metabolic activities, and our energy source is carbohydrate-based to start. At that point, insulin actually secretes a certain amount of what's called somatostatin, induces the anti-growth hormone called somatostatin to be produced to basically take it away. So think of it that way. We're using one, so when we're using insulin, we're shutting down growth hormone. When we use growth hormone, when we have at a growth spurt, as you had when you were puberty or thereafter, that somatotropin basically said, okay, insulin, we're not doing that. We're going to generate growth. We're going to build muscle. We're going to build skeleton. And we're going to use fat as our energy source. That's why growth hormone is such a perfect performance enhancing drug. It repairs damaged bone, it repairs muscle, and it does so at the expense of fat. So you get lean and rapid healing. It's the perfect performance enhancing drug. Good news. And it is mimicked by androgens, by testosterone and testosterone like substances. They do the same thing. But there are some pitfalls that we'll get to when we start talking about testosterone things. Same thing with growth hormone. Why growth hormone was so valuable in the performance enhancing industry, okay, is that it's hard to detect. It's naturally occurring. We make it. We utilize it now for children when they get those growth charts, those body length, body weight charts for infants, and all those developmental landmarks. When you have a child who's in the 25th percentile or lower, we utilize, years ago, it was hard to find growth hormone. We didn't make it genetically. I mean, I'll bet you all know somebody who, when you were in school, they were very short of stature and they started using growth hormone. I mean, one of the best students we had here, she graduated from Seneca Valley with my stepson. I mean, she's a nursing student here, great, married now. I mean, but she's going to tell me, and she was still very diminutive. I mean, she's barely 5 feet tall. And they said, she probably would have been, under 4.5 feet if they hadn't done that before the growth plates closed. So it's different. So understand that, and that's one of the problems. When you're utilizing fats, now you have a problem because you have fatty byproducts that accumulate. You can lead to cardiovascular problems. When you do the testosterone-like substances, there's other problems. But even with all those fats, You get inappropriate acne in locations where it shouldn't be there. There's things like that. When steroids, particularly, then you get the steroid rage, and you get, unfortunately, you're using anabolic steroids, a la testosterone. Now you get that negative feedback when they're present. It doesn't release, which you'll see one of the release hormones we'll cover here called GnRH, gonadotropin release hormone, and that means that, frankly, the testes and the ovaries become somewhat dysfunctional. So I'm thinking all those big, the WWE wrestler type guys, like that. And I'll tell you more about it. Having met Barry Bonds pre-steroids, he was paid 5'10" or 5'11", weighed maybe 185 pounds. Best darn ball player I ever saw. I watched a lot of ball players, all-around ball player. And then all of a sudden, for him to be 6'2" and 230, I mean, when I met him, he's 25. He was 20 years out of college. He was 1989. With the Pirates, he's probably 24, 25 years old. You're going to tell me that 10, 15 years later, all of a sudden he grew 3 inches and put on all that? Oh, not without BLTC, better living with chemistry. Even though he never tested positive, he looked the same as any one of us by and large. You would never have thought that the head, enormous size. He was, it's like he was 5'11", 185. Great ball player. Oh, not such a good throwing arm. Anytime Sid Bream beats you, I ran faster than Sid Bream. He couldn't throw him out from second on a single when the Pirates didn't get to the World Series. Go figure. I'm not even a Pirate fan. Okay, so these are glucose sparing or anti-insulin effects, as you can see. Glycogen into glucose, but principally fatty acids for use as fuel, and then it encourages all the cellular things. Liver, skeletal muscle. They call them insulin-like growth factors, so they stimulate growth similar to insulin. We don't go into it in this class. If you're going to go into a field like endocrinology or the medical school level, research level, you'll delve into them. They cellular uptake of nutrients for cell division, collagen and bone. Like I said, it's really directed to that kind of repair. Connective tissue, bone repair, most cells to enlarge and divide, but the big targets, bone and skeletal muscle. Why it's so useful. So you have a releasing hormone and you have an inhibiting hormone that come from the hypothalamus. And so low blood growth hormone or glucose or high amino acid levels will trigger this. So certain kinds of meals, we can almost generate this. If we use, it's like low carb, ketogenic or low carb meals, you're sort of trading off on this a little bit. And so that's why, and we see that a lot because you're utilizing fats. One of the great things, recently in the last couple of years, 40 pounds on it. First thing you notice, that belt, those clothes start to fit. You don't have that button that's protruding out. You wouldn't know. You're too skinny. All of you. Not me, I just would do this in a shirt with buttons. Oh. So growth hormone, so as you can see, inhibiting, increasing growth hormone or insulin-like growth factors. And this is another one when you're hungry to some extent, it stimulates it. That's there. Without going through all of those, growth hormone, anterior pituitary tumor, if it's before the growth plates are open, gigantism, either way it's spelled. Once they're closed, acro means the tip areas, but you begin to see enlarged jaw, enlarged bony structure, enlarged hands and feet. They widen and elongate, but principally widening, and it's very facially deforming. They all these have PowerPoints. You'll see classic photos. You see it every anatomy and physiology, you get endocrinology textbook. And so here's pituitary dwarfism, which is involved with hyposecretion. Again, now we have ways to correct it. So not a big problem in adults once that it's not being produced in excess. And now certainly we're more limited. Problems are more limited because of the availability of growth hormone. And they inevitably show you these pictures. that are there. And you can think of some famous athletes, basketball players. Manute Bol was that kind of, was like 7'6". There was a guy from Brigham Young who was that kind of size. I remember his name, played for the Sixers. Manute Bol was good. Dikembe Mutombo, the late Dikembe Mutombo, played for Georgetown and for Denver and Seattle. Great player, great defensive player. He was 7'4", but I mean he was fairly well proportioned for that. He was just unusually tall. And again, if you, historically, there's a lot of, there's some, the Watusi were a very tall tribe, typically of men and women who were very, very tall. Men typically were 6'8", 6'10", 7-footers. So whether that was his tribal, I don't know. Because you want to read about an interesting fellow who died, unfortunately, relatively recently, Dikembe Mutombo. Somebody who put all the money he made to very, very good works in sub-Saharan Africa. And so, yeah, we'll stop it here. We don't have to stop this. We'll get through these thyroid and adrenocortical and the other ones. Then we'll get to specific other glands. Thank you. So we'll start the heart in particularly, not so much heart, but conducting system and cardiographs inlet. I think I'm tired.